Thank you very much, Dr. Magdi, for the nice introduction. It's a great pleasure and honor to have such joint session with the European Society of Cardiology with these distinguished speakers. Actually, this is my presentation. It is published in the European Heart Journal 2025. It's state-of-the-art review, non-ST elevation acute coronary syndrome, understanding full spectrum to guide management. And as we all know that comparing ST elevation MI with non-ST elevation is more frequent. Patients are older and with more comorbidities. And if we compare women with men, women are older than men and at the time of presentation with more comorbid conditions such as hypertension, diabetes, and renal insufficiency. Initial mortality with non-ST elevation is lower than ST elevation, but mortality equal, and it is more on long-term follow-up. And this is from the GRACE registry showing that in the first 50 days, acute coronary syndrome presenting with ST elevation, it has a higher risk of death. After 15 days, the risk is equal, and after that, the risk of mortality from non-ST elevation MI is higher than ST elevation MI. Diagnosis of acute coronary syndrome depends on symptoms, ECG changes, and biomarkers, mainly high sensitivity C-reactive, high sensitivity troponin. Fortunately, I did a case 2 days ago, just the day before the conference, and this was a 78 years old Egyptian lady presented with accelerating anginal chest pain, 1 month. It was a Canadian Cardiovascular Society class 3 to 4 at time of admission. The major risk factors was diabetes, long-standing diabetes, hypertension, dyslipidemia. Her examination was unremarkable, blood pressure was fine, heart rate, saturation was okay, and no significant past cardiac history, no significant relevant medical history. We will see what we have to do with such case based on this new state-of-the-art paper published in the European Heart Journal. As regard her ECG, has typical symptoms, and this is her ECG showing ST depression and T-wave inversion as we see, V3 to V6, and also in the inferior leads to 3 and AV and AVF. Let's discuss the prognosis of ECG findings. We can find that based on also GRACE registries that more than 40% of patients presenting with non-ST elevation myocardial infarction have normal ECG. And 12% have T-wave inversion, 31% have ST depression, and 16% have both ST depression and T-wave inversion, like the case I saw 2 days ago. The worst prognosis is that in patients presenting with ST depression and T-wave inversion. Also, the sum of the T-wave of the ST depression in the precordial leads is one of the prognostic factors that we have to look at. And sometimes we have what we call Willen criteria. Willen criteria which is equivalent to ST elevation MI, and this patient should go to the cath lab immediately. And this shows that if we have a myocardial injury, this myocardial injury could be due to non-ischemic myocardial injury like acute heart failure, sepsis, myocarditis, trauma, or due to an ischemic injury. An ischemic injury could be due to type 1 myocardial infarction, either non-ST elevation MI or ST elevation MI, or type 2 myocardial infarction due to the presence of tachy or bradyarrhythmias, hypertension, crisis, or hypotension, other factors like this. The indication of coronary angiography in this case is different from the previous one. Coronary angiography previously was done to do intervention in such case, but it is mainly used for confirming the diagnosis. So we have twofold indication of coronary angiography. The first one is to make a definitive differentiation between type 1 myocardial infarction and type 2 myocardial infarction. We may not be straightforward without coronary angiography. This is one of the important indications of coronary angiography, not only to go for invasive procedure, but also to diagnose type 1 and type 2 myocardial infarction, and second, to assess the possibility indication for revascularization, and we will discuss this in this case. we will have either non-obstructive coronary artery disease or obstructive coronary artery disease. If we have non-obstructive coronary artery disease, that a lesion of less than 50%, we can work for such a case like a patient presenting with Minoka. So if we have a suspicious of plaque in this condition, intravascular imaging is very important. And intravascular imaging in acute coronary syndrome, OCT is preferred over IVUS because ECT can visualize very perfectly the thrombus and coronary dissection. So by intravascular OCT imaging, OCT, we can detect plaque rupture, plaque erosion, or calcium nodule to explain the non-ST elevation acute coronary syndrome, or we can find a thrombus due to coronary embolism or spontaneous coronary artery dissection. If we didn't find this, we have to go to do some provocative tests like injection of acetylcholine to diagnose vasoactive angina or epicardial coronary artery spasm, or to inject adenosine to diagnose coronary microvascular dysfunction. If we have normal coronary artery in this condition, we can ask for cardiac MRI to exclude myocarditis, Takotsubo, cardiomyopathy, or non-ischemic cardiomyopathy. And if we excluded this, so the diagnosis of Minoka is there. If we have obstructive coronary artery disease, like the case I will show you now, so if we have a single vessel disease, so the culprit is very clear. We can go and do the culprit PCI, but if we have multi-vessel disease, which is very common in patients presenting with non-ST elevation myocardial infarction, either we can detect the culprit. If we were able to detect the culprit in patients with non-ST, go do the culprit and do the other lesions in another session. Or we can do this guided by physiologic assessment. And again, this is actually the case. I did it 2 days ago. It's a 78 years lady, and this here coronary angiography definitely have calcification, a very critical ostial lesion in the circumflex and mid lesion as well. And also the LAD has a significant mid lesion. The right coronary falls retrogradely, as we see here, denoting a chronic total occlusion of this right coronary artery. So, what are we going to do in such case? This case actually, based on Grace risk score, it is more than 140, so it's high or very high risk, and intervention in such case is important. So, the physician who did coronary, I'm not the one who did coronary angiography, but the physician who did coronary angiography referred the lady to surgeons, but surgeons declined her and refused to do surgeons. That's why she came to me and I did for her the intervention. And as we see now, it is not always easy to identify the culprit lesion in non-ST elevation acute coronary syndrome. Sometimes it's difficult. In only 30% of patients we can know what is the culprit lesion, and in this situation, most probably the culprit lesion is the critical ostial circumflex lesion. But doing such lesion, we have such case, we have to do the culprit extending to the left main, so we have also to deal with the LAD as well. And this is actually what we did. We did lesion preparation, dilatation, stenting mid-segment of the LAD, lesion preparation mid-segment of circumflex, then stenting left main to circumflex. This is unusual. Actually, what I do to stent left main to the LAD, but the LAD size was smaller than circumflex and the angle was narrow. That's why I decided to stent left main to LAD. Stent was 3.5 millimeter, and then we did what we call POT or proximal optimization with a 5 millimeter non-compliant balloon for the left main. And what I did is a reverse tab. I put a stent in the LAD in a reverse tab manner. I did CAS. Then I repeat POT again. And this was, I will go to the final results, and this was the final results of the patient. Okay. And this was an acceptable one. The patient is doing very well, discharged from the hospital yesterday, and she's doing well now. This is my conclusion for a non-ST elevation acute coronary syndrome. Actually, it includes a wide spectrum of clinical and pathophysiologic presentation of coronary atherosclerosis whose diagnosis and treatment require assessment for spontaneous myocardial ischemia, myocyte damage, and various degrees of coronary artery disease. Typical symptoms, ECG changes, like this case, high sensitivity troponin also, which was high in my case, have been shown to determine initial diagnosis and risk stratification. Timely coronary angiography should no longer be considered on the possible strategy for optimal options in non-ST elevation acute coronary syndrome, but rather a key component of the initial diagnostic evaluation to exclude other ischemic or non-ischemic conditions with similar clinical presentation and to guide revascularization in patients with critical coronary artery disease. Post-acute treatment is very important as well and should be focused on disease-modifying approaches and patient-tailored antithrombotic therapy, especially dual antiplatelet therapy, lipid-lowering therapy, beta blocker, and other medications to modify treatment and to improve prognosis in such critical patients. Thank you for attention.